I'd like to extend a warm welcome to everybody who's here tonight. For those of you, is it their first meeting? Do you want to put your hand up? Okay, and some of you were there last year. Wonderful. Well, welcome everybody, newbies and people that came last year, and a really warm welcome to wonderful clinical professor Stephanie Watson and Ellen Brody, who has done the most amazing things by getting the word out there about the club. Working with Safe Sites is always such a support, and we're really grateful to be given the facilities, plus making tonight possible through them. So also like to extend a welcome to Margaret and Mark, say thank you very much for coming tonight to share your expertise, to keep us informed as well. And for those of you that don't know me, my name is Michelle Urquhart. I am a patient who has gone through extensive surgery with keratoconus, and it's been quite a journey. A lot of you have probably already heard most of my story, so I won't bore you with that tonight. But if you would like to come up and talk afterwards, that's what tonight's about. We share stories, we share our experiences. Please do. It's an age of technology and an age of information, an age of so many things that we can get through Dr. Google. And I think when we have medical issues, it's very, very easy to get caught up in a huge amount of too much information. And this is something that running this Kera Club, I think, is about. We need to be able to sift through that, but we need to do it together. And we need to support each other, because living with keratoconus shouldn't be living alone. When I was diagnosed with keratoconus, I didn't even know what it was. I was only just starting to learn what the cornea was in biology in year 11 at school. And obviously I know very well what it is now. But it wasn't until after my first corneal transplant that I met the first person who had keratoconus as well. So you can imagine it's, you know, all of you have your stories and your journeys. And I hope that we can share a little bit of that tonight. But we're also going to come away far more informed because of our wonderful experts who are going to keep us up to date. We're going to find out about the latest research. We're going to find out about the registries for cross-linking. We're going to find out about options with contact lenses. And there will be a question and answer at the end. So please enjoy. Please don't be afraid to ask questions. You'll be given your chance afterwards. And now I'd like to invite Clinical Professor Stephanie Watson up, please, to talk to us.
Okay, so welcome everybody, and thank you, Michelle, for the introductions there. So the cornea, as you know, is the window to the eye. But sometimes, you know, things don't always go as planned. And in keratoconus, the cornea starts to bulge and change shape, as you know, and it's said to progress. Now, in keratoconus, it typically progresses under the age of 30, and then it sort of stabilizes for many people, unless they're doing a lot of eye rubbing or sometimes have other conditions. Now, children with keratoconus, when it begins in childhood, can have much more severe disease and much quicker and faster progression. So the whole purpose of corneal cross-linking, which is actually the first treatment able to stop the progression of keratoconus, is to stabilize the cornea. So if your cornea is progressing, then cross-linking is designed to stop that. How I like explaining it to patients is that we have the cornea is a bit like a sandwich, and in keratoconus all those little toothpicks have come out and the cornea has sort of become a bit sloppy. And what happens in cross-linking is we put the little bridges back in and the cornea stays more stable. Now, so traditionally it's done using what's referred to as the Dresden protocol. And this protocol has the most evidence available on it. And what it involves is taking the epithelium, the skin off the eye, giving riboflavin eye drops for about half an hour, and then using a UV light. But there's, in medicine, particularly in cross-linking, there's been a lot of developments, and the developments have been quite rapid. And so what is now being done in the clinic is way ahead of some of the high-quality published evidence. And so there's new protocols. And the aim of these protocols is to treat corneas that are thinner because traditionally if you're below 400 microns of your cornea, you can't have cross-linking. Also to avoid taking the skin off, because those of you that have had cross-linking will know that's pretty painful and there's a risk of infection. And the procedure is pretty boring, so some people are trying to do it quicker. Some people are also looking at whether you can combine it with refractive surgery to try, look, if we're making our sandwich better, can we actually make it an even better shape? Can we make it a fancy sandwich? And ways of getting the riboflavin into the cornea. But in assessing sort of keratoconus and deciding, you know, who needs it, it's important to think about, well, what is progression and how do we measure progression? And generally we do that by using topography, which I'm sure you've all seen if you've got keratoconus, which is the coloured images. And what they are is they're like a geography map of the cornea. So they show you where the rises and bumps are. But when we measure a cornea with keratoconus, the topography can be quite variable depending on how bad the keratoconus is, because the machines are all set up to sort of measure normal corneas the best. And so when you get a cornea with quite advanced keratoconus, sometimes the measurements aren't as accurate. So if you have a normal cornea, there's about 3/4 of a diopter variation in the measurement. But when you've got advanced keratoconus, it can be up to 3 to 4 diopters. And so when your corneas are being assessed, you have to bear in mind that sometimes it can be difficult to tell progression because the measurements can be variable and often need to be repeated. Now, what about the outcomes of cross-linking? Should people be having it? Well, recently there was a multi-centered clinical trial of corneal cross-linking for people that had laser-induced ectasia. So that's a condition that looks like keratoconus, but happens after laser refractive surgery. And this is quite a large study looking at multiple centres. And interesting, what they found is some patients did well and some patients didn't do that well. Some patients actually got steeper corneas and some patients actually lost vision. So, so there's a lot that we don't understand about the cross-linking procedure, and people have tried to answer this with clinical trials. But it takes a long time to enroll people in clinical trials, and by the time the trial's finished, the treatment that's going on in the clinic is often changed. And when you enroll a clinical trial, you look for the perfect person, and there's very strict criteria about who you put in. And so we've set up a registry to get really large patient numbers, but also to look at what happens in clinical practice, like what's happening in the real world, not what's happening when you get a perfect bunch of patients who come for a perfect number of visits and use the treatments in exactly the same way. So here at the SAVE site, we have established the SAVE site registries. And what they are is a tool to establish the outcomes of treatment. Patients opt out, so we don't have to go through a lengthy consent process, but if you don't want to be part of it, you can opt out. And your data is anonymous, and it goes into a central pool of data that we can access and analyse. Now, some of you may have heard of macular degeneration. It's a very common cause of blindness in the elderly population. And there's two types. One of it is called dry and the other's wet. And in wet, you get blood vessels bleeding at the back of your eye. And with that, you can suddenly lose vision. Fortunately, a treatment's been developed for that. But that treatment involves injections into the back of the eye. And you have to have that every 2 months for the rest of your life. I was at the Ransco meeting on the weekend, and Professor Mark Gillies was giving a talk on that, and he said he tells his patients, if I see you in if I see you in the street, or no, if you see me in the street, you better be scared because I'll be giving you injections until either one of us dies. so it really is a lifelong treatment. So he originally set up this registry to track, well, what if you're going to give people this, invasive treatment for the rest of their life? What is the outcomes? And this is sort of a patient that's received treatment for the macular degeneration, and it's tracking the injections and the outcomes. And this is now, this registry system for AMD is the largest collection of data in the world on macular degeneration. And the Australian data is actually showing that patients in Australia do well because there's incentives around injections compared to other countries. So the UK results, the UK have started using the registry and it's not as good. So with all this in mind, I thought, well, we need a registry to track what's happening in keratoconus. And so I set up the Fight Corneal Blindness Project, and it was called that because the Retina Project was the Fight Retinal Blindness, and we've got a keratoconus registry. We also have a glaucoma registry that's just been launched, and we have registries planned in oncology and uveitis. So what it is, it's a national registry, but it's actually now gone international. So we have centres in Australia. We have about 40 centres: Australia, New Zealand, France, Vienna, Switzerland, and Italy. And the aim is that when you go and see a doctor, instead of all that information the doctor writes down sitting in the patient's file and never seeing the light of day, that data can be collected, put into the system, and then everyone can benefit from that knowledge. And what the Retina Registry can now do is give the doctors an idea of how their patients are going compared to everyone else on the registry. So this is Mark's slide, and he's showing this is the top users, top 25% users. And he's saying that's his patients there, but I think that's a bit of a joke. This is what you can do with the registry. And so what we've just done for the Keratoconus registry is release benchmarking reports. So all the doctors that are using the registry can go in and with a click of a button can get a report as to how their patients are going compared to the rest of the doctors in the registry. And so this way, patients that are treating people with keratoconus can know whether their treatments sort of align with what other practitioners are doing. Patients can also see with the registry their treatment journey, what's been happening with their vision and their corneal shape. So this is a patient that had cross-linking. So I first saw the patient in about 2007, and then their vision declined and their keratometry went up, and then they had cross-linking and the cornea stabilised. We also are collecting patient-reported outcomes. So there's been an emergence in medicine or a renewed interest in medicine of collecting what we call patient-reported outcomes. And there's a study in the US that looked at in an orthopedic centre that looked at using a very sophisticated piece of machinery to measure how patients did after knee surgery. They then gave the patients some questionnaires and asked them, well, how did they think they went before and after the surgery? And the results from the expensive time-consuming machine were pretty much the same as the results of the questionnaires. So we've included in the registry a questionnaire developed by Professor Konrad Pezogov's called the Cork, and it's a validated questionnaire that we can use to find out from you what you think about your keratoconus. So it's not just up to the doctors saying, well, this is what we think. You know, you're able to tell us what you think. And that way, when we analyse that data, we'll be able to find out the true patient benefit of treatments. Now, this is the data from the orthopedic centre. So the top graph is the results from the questionnaire, and the bottom one is from the machine. And they align pretty closely. So how does in my clinic, my orthoptist, you know, when you come see an ophthalmologist, often you'll see an orthoptist and she'll see you first and check your vision, do the topography scanning and enter some of the data into the system. While you're waiting, you can complete the patient-reported questionnaire on an iPad, and then during the consult, I'll review and finalise the data and look at the score for the CORQ. It's approved by RANSCO, so all ophthalmologists have to be part of the Royal Australian and New Zealand College of Ophthalmologists, otherwise you can't practice. And to be part of that, you have to get your brownie points, and they're called CPD, which is Continuing Professional Development Points. And to get those points, you have to look back at your practice and audit your practice and show people that you've reflected on it. And so if practitioners use the registry, they can get their points to show that they're maintaining their education. As I was saying, the registry's now gone global. And this is an update on the recruitment. So for keratoconus, we have over 2,000 eyes. from over 1,200 patients currently stored on the registry. And each time they come to the clinic, it's a visit, and we have about 11,000 visits with 1,000 cross-linking procedures. We now have 40 sites, and the visits have been growing. So we've just started to analyse those results. We wanted to wait until we had a good cohort of data before we started looking at them, and over the next year we'll have increasing amounts of detailed results coming out. The registries also picked up some adverse events from the procedure, and it's important to be aware that you can get HAZE. Fortunately for most people, the HAZE is temporary. You can get trouble healing your cornea, infection and scarring. So this is a picture of what HAZE looks like. And so for your vision, that'll mean that vision will be a bit cloudy. But fortunately, most of it disappears. So what are the benefits, of using the registry system? Well, the doctor can help to use it to see what the results of their treatments are and what in altering, their protocols, whether that is beneficial. They can look at graphs of your progress. They can get summaries of how their practice is going. And they can become Mr. Fabulous or Mr. Marvelous or Little Miss Fabulous in doing so. The benefits to you is being able to track your treatment journey. Your data will be contributing to finding out what is the best practice in the treatment of keratoconus. And the data can, if you change practitioners, that data can be referred between the practitioners, so it gives a bit of continuity of care. So currently, cross-linking, it's the only treatment we have to prevent the progression of keratoconus. So having said that, if you're not progressing, it's not really needed. It's really to treat progressive keratoconus, and the methods are evolving. There's people are looking also at other areas outside keratoconus to do the treatment, but because the evidence is evolving, we need to keep monitoring the outcomes. We want corneas that look like this, not the sloppy one before, and we need to know the best way to do it. So I'd just like to thank the team that's been working on the registry. And including Mark Gillies, who set up the registry platform, and also the clinicians that are currently on the steering committee across Australia. We've had funding from the Ophthalmic Research Institute of Australia, Keratoconus Australia, the Claffey Foundation, and Mr. Larry Kornhauser. Thank you.
I want to thank Safe Sight and Kera Club for inviting me today. I want to thank you guys for making the time that you've invested in finding out about what the best treatments are for your eyes and what the best opportunities are to restore your eyesight. The talk that I have prepared is to keep you awake and also to present some very serious things with a little bit of humour, because, we've got to laugh about certain things in life as well. So there'll be pop culture references and just a little bit of fun as well. So The Matrix is one of my favourite movies. The topic that we have today, and the disclaimer is this: Mark and I are colleagues that are very friendly. We both specialise in looking after patients with keratoconus for their contact lens needs and for monitoring to see if their condition gets worse. And in friendly competition, we both want to win. So we both want to educate in a fun and friendly way. So, there's going to be a bit more of a relaxed approach about the slides today, and some important facts for you to consider about correcting your eyesight with contact lenses. Now, the topic is bigger actually better when it comes to contact lenses? And I couldn't leave that, great thing unsaid. So Mark will say that the bigger contact lenses are great. Mark will say that they're safe if they're used really well. Mark will say that they're newer technology, so therefore whatever's newer is going to be better. Sometimes they can handle worse cases of keratoconus when they're a larger lens, and bigger lenses can therefore cover more areas where your cornea might be irregular. But I will clearly demonstrate via some of the case studies I've seen in my practice to prove that bigger isn't always better. So these case studies can also demonstrate that sometimes when they're prescribed by the wrong, inexperienced hands, if we're not careful enough, we could actually be doing harm to some very fragile corneas. And there are many cases where I've inherited patients where contact lenses have not been utilized wisely, so they've definitely caused complications by not being properly prescribed. I have to also say that in the vast majority of cases, when you look after your eyes really well in the hands of experts, we're not going to see these cases. So these are quite extreme cases and more to do with the spirit of competition of wanting to win this debate than anything else. When you think about it, it's also much safer because we've got a long, detailed history. When people have been prescribed smaller contact lenses, we've used them for a much longer period of time, many, many decades more. And when we prescribe smaller lenses and they work, they've got a longer history of safety and performance that we can rely on. So therefore, the logical approach is actually that if smaller lenses don't work, it's only then that you should really start to consider more complicated lens designs. So Dr. Spiderman says, with great power comes great responsibility. And I have to agree, because really when you look at it, bigger isn't always better. What I mean by that is that just because that argument that it's actually better technology doesn't necessarily mean that it's true. If you've got a larger contact lens, you've got more data points that you have to get accurately. You've got more chance for complications. You've got more accuracy that you have to deliver to deliver an optimal outcome. When you look at a contact lens and you look at a very fragile cornea in blue there, you've got more points that you have to make sure that you clear the cornea. You've got more biomechanical stress that might be placed on the cornea with a heavier lens, and you've got more measurements that you have to take to design and calculate. You've got more curves to fit just right to make it work perfectly. You certainly need more instrumentation. You definitely need, exactly what Stephanie says, a really good topographer to be able to take a 3D measurement of the eye in detail. And most practices that don't specialize in keratoconus don't have this sort of equipment. The extra expertise that I mentioned is about not everyone fits rigid contact lenses, as you guys may have already experienced. How many of you guys have had an experience with contact lenses already? Hands up. And how many of you guys have had an experience with contact lenses that you would regard to be not the most pleasant experience with contact lenses? So we're seeing almost 100% of the hands go up in the air, and that's exactly what I mean. It needs extra expertise. So not everyone fits rigid contact lenses, which unfortunately most keratoconic patients learn the hard way. Not many people fit it really well. And unfortunately, even amongst those that do, all of them understand that it is fairly complex, it can be very challenging, and it can be challenging to have all the expertise you want to master all the intricacies of handling complex cases, let alone finding a practitioner who's experienced in fitting more complex and larger scleral lenses. So because without a doubt, the larger the lens, the more surface area that has to be expertly designed, the more complex the design, and actually the higher the chance of corneal complications. This means that it's not just an uncomfortable lens or an uncomfortable experience for you, but it means a suboptimal outcome in rare cases too. It can potentially damage your ocular health, and by increasing the chance of complications, such as if you look at this patient here that I inherited, you can see all these fine, small blood vessels that are growing across his cornea. If you've got a contact lens that's creating a lot of biomechanical stress, and this is what happened to this gentleman, he had a contact lens that's created a lot of corneal opacification because of the scarring that's happened on his eyes from a contact lens that was fitted where it was rubbing too hard on top of his eyes. And it created a lot of blood vessels that were growing into his eyes as well. Now, when that happens, not only does it interfere with your vision, but if the lens keeps landing too heavily on the limbus and we don't realize it, or it's not something that the patient realizes either, that can also cause limbal stem cell deficiency, which Stephanie is an expert in, and as she would tell you, as would most ophthalmologists, it's extremely difficult to manage and resolve. The scarring that results and the subsequent loss of vision is very serious. The problem is that the worst of these complications for keratoconus even jeopardize the chance for successful corneal transplantation. Because the beauty about why corneal transplants have such a high success rate for a body part to be transplanted is because the cornea is avascular. It doesn't have blood vessels. If suddenly you've induced so much biomechanical stress on that cornea that there are blood vessels growing everywhere, we know from our journals and our studies that now this cornea has got lots of blood vessels growing through it. It has a much, much higher chance of rejecting a corneal transplant. So consequently, if you If you have an experience where unfortunately you fail with the patient with prescribing contact lenses poorly, and like I said, it's not something that would happen in every case, but it's something that we have to be mindful of in the choosing of who we choose for our eyes. And if you cause irreversible corneal complications, then all avenues of sight restoration can be completely lost for the patient, or at least in terms of their risk of success, it can be jeopardized. So one case study, and I just will disclose that these are certain patients that have come from my practice, and all of these patients have volunteered to say they've given consent to discuss for the purposes of education. So Anna Peake, with a name change, late 20s, lovely lady. She does admin duties. She's a secretary. She's currently managed by someone who her ophthalmologist at the time referred to as a specialty contact lens optometrist and was regarded really well. She's been wearing her scleral for the last 3 years and has never known any different. And I see this, and even without training, you can see that this is a contact lens that's not happy. It's fairly dirty. There's a lot of tear film debris. You've got lots of blood vessels that are growing everywhere when you look closely enough. The tear film debris and protein is all over the lens. When you look closely enough also, you can see that there was suboptimal care instructions given in the whole TLC of taking care of this patient. This patient also was advised it was perfectly fine to use tap water for cleaning, and I'm sure that Stephanie likes the sound of that. So the central clearance in this lens was insufficient. You can actually see that there isn't even enough tear volume here to fill the lens up, so the edge of this lens isn't fitting nicely where we want that lens to fit nicely against the cornea and against the limbus. And there's a very poor edge design all along there. We've got too much debris all over the place, and the poor care instructions and design make me really question how this was fitted. My moral is it's easy to make mistakes even amongst experienced practitioners. Sometimes health outcomes for patients can be jeopardized as a result, and these health outcomes we need to be very mindful of being careful of when the patient has contact lenses that are prescribed. They need to be prescribed very carefully. I don't want it to burn a bridge for a patient that later then requires corneal transplantation, and then that jeopardizes it because of the contact lens induced complications. So it's something that we have to take, like Dr. Spiderman says, we have to take great responsibility in looking after our patients. This is the same eye refitted with a much better lens design. I've reduced the lens diameter. What happened on follow-up was that the blood vessels that had grown had started to regress back, and we get what's known as ghost vessels, which means that the vasculature has changed and you can't undo what's done, but at least the vessels are quiet, they're dormant, the eye's happy, she's seeing well, she's happy as a result. The graft is happy as well. So you can see some of the old vessels that are dormant here, and you can see some of the old ghost vessels there just towards the graft as well. So Adam L is my second case study. He's a construction worker. He's a Pacific Islander. I love Adam. He's really nice to look after. He's very grateful as a patient and a very lovely person. He doesn't mind his keratoconus because he says the best thing about my keratoconus is that my wife is always a designated driver at night time and I'm always allowed to drink. I don't feel so comfortable about knowing that when I know that he's a construction worker wielding tools with 645 vision and counting fingers out of his other eye, his best vision that he can see at 50 centimeters, mind you, and that's all that he can see. But once we fitted his lenses, we got him down to 6 out of 7.5, so I was pretty happy with that. This is his eye. You've seen his eye earlier, and again, his eye was the case that I showed you where there was a lot of scarring, and the scarring that happened was because the last contact lens he grew out of without realizing it, and that stresses also the importance of regular visits, even if you feel like everything is fine. So the contact lens had been rubbing against his cornea for a really long time, and that had also triggered a lot of biomechanical stress and a lot of the blood vessels growing, as you can see where the grey arrow is there, and there, and there, and there, and there, and in fact all over. So the most important thing is that after he was fitted with new contact lenses, again his vision came down to 6/7. He had regression of his corneal neovascularization, so the blood vessels went back. He obtained his full driver's license, so he had no longer any excuse not to drive his wife when they went out together. And more importantly than not, he was back to work safely and is back on track again. This is the kind of scarring that you'll see if a contact lens isn't fitting right. and it's a long-term thing. When you have scleral contact lenses, it seals everything in. If it seals everything in and you're not given the right care products to use, it can result in trapped metabolic byproducts, and it can create a toxic metabolic soup of different products that are under there that can be pro-inflammatory and drive that blood vessel growth or drive complications. So how do we ensure the right fit? Some of it is the fact that we're very lucky. One of my mentors is sitting in the room, David Pye, who was the head of school when I was at University of New South Wales. We have access to much better technology now than we used to. We can now manufacture lenses to the nearest 1,000th, 2,000th of a millimeter. And some of it is also just making sure when we look under the microscope in the room, we're making sure that the lenses are not fitting too tight on the limbus or too loose when you see a little grey bluish edge. We now have OCTs that help us determine that. But often also, you know, they're very subtle signs and it's not that easy, particularly with larger lenses. So case study 3 is Anna G. Anna G is in her mid-30s. She was referred by another optometrist. She gets 624 and 6 out of 21 vision. As you know, 6 out of 6 is what we'd love to aim for perfect vision. She thinks, well, it's been 2 years. Medicare tells me I get checked every 2 years. So it's now time for me to get checked again. That might be true for someone who's regular. With keratoconus, I would really be reluctant to look at someone anything beyond every 6 months, especially if they're in contact lenses, because we really need to see that everything's still going fine with their eyes. So again, Dr. Spider-Man, with great power comes great responsibility, as he's saying, and this is Anna G. So if you look at her eyes, you can see the green fluorescein we always put in your eyes when we check on your lenses in your eyes. That tells us how much tear film is underneath your contact lens. So in essence, it tells us how much buffer is underneath the contact lens. Before that contact lens touches the eye, you've got a whole body of tears, hopefully, so that it cushions the impact. So this looks like she's got lots of tears underneath, but concerningly, there's no tears in the middle where you can see the contact lens in the middle. And so when you look at it under white light, you can see that some of the scarring has really started to show. And she's just come in thinking, it's time just to change my contact lens, please. And I'm sure everything's going to be okay. And I had to, and this is her left eye, and I had to break the news to her that there had been a lot of scarring that built up in just a 2-year period, because it had probably been a little bit too long between visits for her, and to do it 2 years between visits. So, you know, I could get her to 6 out of 12 and 6 out of 18, and there was an improvement in her vision. She's happy enough with that vision with 2 eyes together. This Anna is actually a patient I've been looking after for the last 3 years. I saw her again 2 weeks ago, and I'm pleased to see that now the scarring has sort of faded with time with a better lens. So now she's getting about 6 out of 9. So she's really getting full driver's license vision again, and a lot less of the halos and the clouding and problems. Should we do one more case study? Yeah? Okay. So Songmi L is in her early 40s. She said, I'm a bit worried because my eye is going white. And I had my contact lenses fitted in Korea. She's in her early 40s. She was referred by another patient. And I was expecting to see maybe a fitting for her lenses that didn't look so good. This is her right eye. You can see maybe just with a little bit of creative imagination, you can probably see a little bit of white opacification right where her pupil is in her right eye. So I said, okay, I can see that we can get you to about 6 out of 9 with testing. And in her left eye, this is the concern. This is what we could see. And, you know, there's a lot of complications going here. She had poor fit, she had lots of complications, she had a few different things happening at the same time. And all of that led to inability to try and be able to improve that eye. Both me and her ophthalmologist decided that it's really best to try and let that eye settle as best we can. We're not sure if surgery or contact lenses will improve things. We need to let it settle first, and there's a few things that she's on treatment for to try and, like topical steroidal drops to try and settle it down. And that concern is about limbal stem cell deficiency as well. So in conclusion, Mark will say they're great contact lenses and they're safe if they're used well. And although they're newer technology, I've clearly demonstrated by case studies that we need to take a conservative approach. If small contact lenses don't work well, or if we know that there are reasons that don't work, that's when we start going to slightly larger lenses. So even in the hands of practitioners that mean well, we have to be really careful at all times in prescribing contact lenses for our patients. Now, this is not something that I would emphasize happens in every patient. The vast majority of patients go really, really well with contact lenses. They make a huge difference to your life, but it's just about making sure that you pick someone who has extremely good expertise in contact lenses. I would trust Mark to fit contact lenses for me if I had keratoconus, but in the spirit of the debate, I found this photo of him on Facebook to slander his name, and also when he visited Alcatraz prison as well. So in conclusion, we all know that bigger isn't always better. It's more important how you use it, and after all, it's the little things in life that are always the best. If a contact lens is well fitted, it changes your life in a profoundly positive, meaningful way. It really makes life livable again, gets your life back on track again, so your eyes are no longer an issue. With the right expertise, complications are extremely rare. So it's important to choose your optometrist wisely and make sure they have a lot of experience with hard contact lenses. And especially with keratoconus, choose someone with enormous amounts of expertise dealing with your type of condition. The stakes are high. The outcome between your eyesight holding you back in life and then a well-fitted lens allows you to be able to do everything you want to be able to do without your eyes and your eyesight becoming an issue. That's why I love helping patients with keratoconus, and I never underestimate the responsibility that is placed in me to do the best I possibly can for my patients, and I love seeing them do really well in their lives with their contact lenses year after year without complications. Thank you.
I'm going to give everybody 11 reasons why bigger contact lenses are better. And whilst I was sitting there listening to Margaret, I actually thought of a 12th reason. So the difference, for those who don't know, the difference between a small contact lens and what we call a mini scleral is about 7 millimeters. So the small corneal RGP, which is what a lot of people with keratoconus were fitted with, I tend to fit most of my patients now with the larger 16.5 millimeter lenses. Margaret tried to mislead you before. She said that mini scleral lenses are a newer technology. She's actually wrong. The first contact lenses fitted in Australia were fitted in the 1920s, and they were scleral lenses bigger than that. And they were actually made of glass. So Ernst Gotz was the optometrist who started fitting patients in the 1920s. One of the Sydney gurus, his name was Penn Thomas, and he fitted patients in the 40s, and he used to put a plaster in the eye. So effectively he's taking a mould of the actual corneal surface and making contact lenses out of that. So they're not newer technology, but there's been a bit of a renaissance with these lenses over the last few years. Okay, in terms of what's the difference, a smaller lens will actually sit on the cornea, it'll ride around the cornea, whereas a larger contact lens actually bolts the cornea. It's actually not sitting on the cornea at all. Okay, so how is this an advantage? Well, the number one reason is they're much more comfortable than what a corneal RGP lens is. All the contact lens wearers here, and who raised their hand before, who said the lenses are uncomfortable, you're wearing the small lenses. The eye has a lot more pain receptors than most parts of the body, 300 to 600 times more pain receptors as a density. So when a small little lens moves around on your cornea, it's constantly stimulating all those pain receptors. The good thing about a mini scleral, it doesn't fit on the cornea at all. It doesn't touch the cornea at all, at no place. Over 360 degrees around the cornea, it's actually not touching it at any place at all. So the second reason why they're better is your vision tends to be more stable. So when the little corneal lenses are actually moving around, the vision becomes unstable and the focus goes in and out. With a mini scleral, it's not moving nowhere near as much, so your vision tends to be more consistent for longer periods of time. Reason number 3, it's great for dry eye. So when you're putting these large lenses in, you actually have to fill them up with a filling solution such as saline or a lubricant drop. And when you place it on the eye, it keeps the moisture under the lens throughout the day. So it's like a little biodome which actually locks the moisture in. This is another reason why it tends to be very comfortable. And this is great for dryness of the eye. So it's great for a lot of these different conditions which cause dry eye. these very serious conditions like Stevens-Johnson syndrome and Sjogren's syndrome, these people with very, very dry eyes, they often do quite well with a mini scleral contact lens. If I can diverge just a little bit, one of my patients who I saw last week, Stephanie might remember her name's Norma, and she has a palsy where she can't actually open one of her eyes. And with her other eye, she was gradually losing her vision because her cornea was actually going cloudy. And she was actually legally blind in her good eye. And when I saw her, she had a cornea which looks very much like that. I actually sent Stephanie an email asking if she'd like to see this lady to actually help her. She prescribed her a drop called retinoic acid, and her cornea has actually cleared up amazingly. She could nearly pass a driver's license test, and that's in the space of 2 or 3 months. So when we talk about the Safe Sight Institute, it's true. You really are saving people's sight with the greatest technology. And this has made this woman's life so much better. So in terms of a study with regards to dryness of the eye, this is a large study which had 49 patients with a range of those diseases that I just measured. It was actually quite a long-term study as well, nearly went for 3 years. And these patients were wearing these scleral lenses for up to 14 hours a day. And a lot of them, half of them had an improvement in their best corrected vision with the contact lenses. But the most really important point here is that 92% of these people reported improvements in their quality of life score. So similar to what Stephanie was talking about with regards to the cross-linking, for people with unbearable dryness of the eye. And a lot of people don't realise that dryness of the eye can be so debilitating that people actually consider committing suicide. So to be able to help them is wonderful. Number 4, they act as a bandage contact lens as well. So they can actually help rehabilitate the cornea. So this is a person who's actually had a corneal graft. As a result of the corneal graft, they developed a chronic dry spot, a persistent defect in the surface of the eye, as you can see by that green pooling of the fluorescein in the centre. And that was day 1. This person was fitted with a mini scleral lens. By day 8, that blob in the centre is actually getting smaller, and by day 16, it's actually cleared up as well. So it acts like a bandage, and we use contact lenses a lot as bandage. So people who have dry eye or who've had a scratch on their eye will often fit them these days with a bandage contact lens, and they'll help the cornea rehabilitate. Okay, reason number 5, they're better for allergies. So you've got this little biodome where the moisture is locked in. Also, the allergens can't get to the eye. So the pollen's floating around in the air. They can't actually get to the cornea or the limbal stem cells on the edge of the cornea, because we know that keratoconus is very much related to things like allergies, eczema, hay fever. Okay, so if you're reducing the ability of these allergens to get to the eye, you're going to make people a lot more comfortable. And one of the important things of helping people with allergies is making sure they don't rub their eyes. So if you're keratoconus sitting in the audience, that's the number 1 thing, is don't rub your eyes. A lot of the progression of keratoconus can stop as soon as you actually stop rubbing your eyes. A study by Charles McMonnies and Gavin Bonham in 2003 found that people with the most severe keratoconus, the eye which was worse was the one they rubbed more often. You know, I've seen people get their knuckles into their eye, particularly men, and they just absolutely rub the crap out of their eye. I had one guy come in, he had a foreign body in his eye, he left it all weekend. Within 3 days he'd given himself keratoconus. He'd rubbed his eye that vigorously that his cornea had gone out of shape, which was unbelievable. Reason number 6, it keeps foreign bodies out. So the good thing is this is good for people who work outdoors. So if you work in a dirty, dusty environment where dust and things like that get under the lens, and for all the contact lens wearers here, that's nearly the number 1 reason why they drop out a lens wear. They get a speck under their lens and it just becomes intolerable. The good thing about a mini sclera, because it's a sealed system, things don't get under there at all. So it's good for people who work outdoors in these dirty, dusty environments. Reason number 7, they don't fall out. I've never had a patient dislodge a mini sclera contact lens, ever. This is an example of an ice hockey game where a guy's contact lens has fallen out and everyone's looking on the ground for it. They've stopped the game. That was nice of the opposition to do that. But they don't fall out, ever. And they're better for life in general. To give you an idea, with a small corneal RGP, one of my patients, Rachel, She said, I was walking up the train station one day and a lady's bag brushed me in the face. My contact lens popped out. And of course, it was the small little corneal RGP lenses. Reason number 8, they're better for swimming. So they are really great for surfers and people who do water sports because you can actually wear the contact lenses in the water. You just got to make sure your hygiene is good. If they're swimming in a river or not a very contaminated water medium, then you need to be very diligent with regards to the cleaning. And the chlorine and salt water is not getting to your cornea as much, so they don't sting as much as well. Okay, reason number 9, they're less likely to break. So I've never had a patient actually lose one of these lenses. I've also never had a patient break one of these lenses. They're 300 microns thick, about 1/3 of a millimetre. They're twice as thick as what a corneal RGP is, and they don't break. I've never had one break. But that's not uncommon with a small corneal RGP. Reason number 10, they're good for peeling onions. Because they're a little barrier, you're not getting the gas, propanethiol S oxide, from actually getting to the eye. So your eyes don't sting when you actually peel onions. I just remembered reason number 12. I said I was going to give you number 12, Margaret. When they do fall out, they're actually easy to find because they're bigger. So all the people who have keratoconus and they drop their contact lens and they can't find it because they can't see. Because these are bigger, you can find them and you can feel them as well. So much easier. Reason number 11. I think they're actually easier to fit. I actually think they're easier to fit than a corneal RGP. When you've got keratoconus, you've got a very irregular shaped cornea. You put a small little lens on it, it just rides all over the place. And fitting it can actually be quite complex. So I actually find this process to actually be easier. If you've got pellucid marginal degeneration, that is nigh impossible to fit with a small corneal RGP lens. You have to go for the miniscleral. But even standard keratoconus can actually be difficult. So this is a patient that I saw a couple of months ago, and Dinara has this small little thick nipple cone right in the centre of the cornea. And this is actually the classic type of case you use for a small corneal RGP. But the devil is in the detail with regards to these patients. So the centre of her cornea, as everybody can see, is very, very steep. That's the nature of her keratoconus. But then I changed the topography map on her and did an elevation plot. So this is not actually relating to the steepness of the cornea, it's actually relating to the elevation. What's the highest part of the cornea? But the highest part of the cornea is now up here. So what actually happens is the lens will actually decenter towards the blue section. So the lens will just continually decenter down there. So even though she's a standard keratoconic, she's not going to be an easy fit. So a miniscleral is a better option for her. The fact that we're vaulting the cornea, the irregularity does not matter. The cornea be completely irregular, we can fit it with a miniscleral. So this is an example. So we use technology to actually fit these lenses, and this is what's called an OCT. It's like an ultrasound type technology, where this is the contact lens here, this is the cornea here. We can actually measure how much it vaults the cornea. And then we can scan that right across the entire cornea to make sure it's not touching anywhere on the cornea at all. This is Dinara's plot. At the top part of her cornea, where it's higher, there's only 136 microns of clearance, but in the centre there's actually 310 microns. So the technology makes fitting these lenses so easy. Okay. All you have to get right is getting the limbal clearance. So on the edge of our cornea, we have these very special cells called limbal stem cells, and they produce new corneal cells. You do not want to insult them at all. So you need a lens which is actually, and this is the T2 section, there's two different curves. T1 is a peripheral cornea, T2 bolts the limbal stem cells. And you want to make sure that it's bolting it and not actually rubbing on the older designs used to touch the limbal stem cells, and that's what caused the failure. Those cases that Margaret is showing are most of the older lenses where they're actually rubbing on this. But this is a very modifiable angle. All we have to do is specify the angle. This might be, say, 45 degrees, and we need to change it a little bit. And the final thing you have to do is get the lens landing on the conjunctiva or the white of the eye better. So it's a reasonably simple procedure. The problem which can arise is people's conjunctiva can be different curvature. So the white of the eye is often a different curvature, horizontally and vertically, and that can be the challenging part to fit. Okay, insertion really isn't that difficult. This is an example of a guy putting his lenses in. You've really just got to make sure that you've got a big enough space to put these lenses in. We use these little suction devices which make insertion and removal very easy. You're actually not touching the contact lens at all, so it's more hygienic. That's number 13, Margaret. So they're actually they're more hygienic than what a small corneal RGP is. One of the things that people worry about is the level of swelling of the cornea. You're putting this thick contact lens on the cornea. Are you limiting the amount of oxygen to get to the cornea? And that's what a lot of people's fears are, and that can cause things that possibly Margaret was talking about. But some studies have shown that that's actually not the case. Ideally, when I fit one of these patients, I want the lens to be vaulting by about 200 microns. Over the course of the day, the contact lens actually sucks onto the eye a little bit and comes closer to the cornea. So we need to have a nice little reserve of clearance. This was a study done at Pacific University, and they had 300 to 400 microns. So the more clearance, the less oxygen which is available to the cornea. So less is better. And in this study, they had different lenses of different oxygen transmission, and they actually found the rate of corneal swelling due to oxygen deprivation was actually quite low, less than 2.3%. When we sleep at night and our eyes are closed, oxygen can't get to the cornea, and our cornea on average swells by 2.8%. So wearing a mini scleral actually causes less swelling than closing your eyes does. So that's not as big a problem as people try to make out. So 11, 12, 13 reasons why big is better. Okay. Number 1, they're more comfortable. Number 2, the vision's more stable. Number 3, they're better for dry eye. Number 4, they're a bandage contact lens. Number 5, they're better for allergies. Number 6, there's less foreign bodies. Number 7, they're less likely to fall out. Number 8, they're better for swimming. Number 9, they're less likely to break. Number 10, they're better for cutting onions. Number 11, they're easy to fit. Number 12, they're easy to find. So I think the evidence is irrefutable that miniscleral contact lenses are much better than smaller corneal RGPs. Thank you very much.
I don't know who perhaps, I like what you had to say, Mark, about contact lenses. I've had 2 corneal transplants and I've had laser surgery 2 times on each eye. So that was roughly 20 years ago since my corneal grafts. I have only just started to wear contact lenses again. It's not something that I like wearing. I think I have the small ones because they move around.
Yeah.
But is it, the question I want to ask, is there an option with contact lenses where you have crisp clear vision all the time? Because that's not something I'm experiencing, and the contact lenses may do that.
Depends on a lot of things. Firstly, it depends on the irregularity of the cornea, whether you have what we call internal astigmatism, because the keratoconus or post-graft can cause astigmatism. You can also have internal astigmatism, so when you put a hard contact lens on, it doesn't necessarily correct that. So that's a factor. Whenever you wear any contact lens, there's going to be a level of drying out, and that can affect the quality of your vision as well. With a miniscleral, you can get things like mucus underneath the lens itself, and that can cause a little bit of a haze. And it depends upon the person. Some people don't produce a lot of mucus, some people produce a heap. And those people, they sometimes need to take the lens out in the middle of the day to give a bit of a rinse and a refill and reinsert in their eyes. It's generally not a big problem, but those factors definitely compounded as well. In terms of patient selection for a miniscleral, someone who's had surgery, I'm a bit more wary about due to oxygen and fragility of the cornea. So you need to make sure that the cornea is robust and healthy, and because there's going to be less oxygen available to the cornea than with the smaller lens. And that's the number 1 reason. So even though these studies have been done on people and shown that there's not a lot of corneal swelling, the cohort of people might not be severe keratoconus or people who have had a graft. So it's very important that we make sure that the cornea is robust enough to actually handle that slight oxygen deprivation. Because when you've got a small lens, oxygen and tears are getting in through the edge, and that's very, very important. But yeah, if the cornea is not fragile, then I think a miniscleral can be a very good option. If you don't have a lot of irregularity in the shape of the cornea, then even a soft contact lens can be not a bad option. You can get what's called a silicon hydrogel lens, which is a stiffer material. So it's stiffer than some other contact lenses, and that can sometimes give you better vision.
I think that's a great question. What studies show is that when a hard contact lens, whether it's large or small, once you go through that adaptation period, if it's a well-fitted, well-prescribed lens, it really should be fairly reasonably comfortable. So I think for the purposes of this debate, we had to have two extreme views, whereas the reality is in practice, the message is that it really should be a very individual approach based on exactly what that eye and exactly what we need based on a thorough assessment. So in reality, Mark will fit small and large contact lenses, and in reality, I will fit small and large contact lenses too. I think one of the things that I should disclose also is for the purposes of the debate, we had to have two very polar opposite kind of points of view. However, there are a multitude of different types of lenses in between your small corneal rigid lenses to, say, a slightly oversized rigid lens so that you can increase comfort. Then you've got lenses such as a hybrid lens, where it's a hard contact lens and it performs as clear as a hard, but if the characteristics of your eye are right, it's also got a soft contact lens skirt, so that kind of hides the whole contact lens, so it feels like a soft contact lens, but you get the vision of a hard contact lens instead because of the precision of the harder material. And then you've got corneoscleral lenses. They're not quite a really big mini scleral or a full scleral, but they half land on the cornea and they half land on the sclera. So then you've got the ability to cover a lot of keratoconus, but also you've still got lots of tear exchange and a backup supply of oxygen with fresh tears coming through. So there are lots of different options, and I think what you probably need is a second opinion to come in and get checked, and then therefore, get a proper assessment.
So it is possible to have a pair of contact lenses that don't feel like
Yeah, absolutely. So if it's been a long time since your last assessment, or also, I think it's really important in this field, the best analogy I have is that we're very lucky in the contact lens field. I feel as though we've got more movement in technology than we get in iPhones and Android phones. So it's important for us to keep staying up to date, and often there's lots of different advancements that we have to stay in front of, and sometimes having an opinion to see if that might change or something else that might work for you will work really well. And there's piggyback options where you've got a soft landing on a hard landing on a soft, then it goes onto the eye, and lots of other options too.
In terms of comfort as well, I always think patients who have got severe keratoconus in one eye are always a good example of contact lens success. I had a guy come in 2 weeks ago, was referred by Larry Kornhauser. He had keratoconus in both eyes, but his vision in his good eye was not too bad. The vision of the other eye was very poor, and he'd worn a small corneal RGP lens, and the vision was very unstable because the lens was moving around all the time and he hated the comfort. And these people did not tolerate contact lenses. The reason being, this eye feels nothing because there's no contact lens in there. They've got to put up with something in this eye, and they have to think about that eye all the time. I fitted him with a mini scleral lens. His vision now driving license standard, and finds comfort wonderful. So I do find mini sclerals are great for people who carry those in one eye.
I'd like to ask about the cross-linking process. I've sort of, for whatever reason, concluded that it's probably better for younger people, and that's the target population. I don't think that's correct. Is it something? So I'd like to ask: is it something we use in an older patient population? What is the target? Are there actually indications of success? Because in the articles I've read, I found it very hard to determine whether it's something that's good to have done or not. So I just have some questions around target age range and suitability, perhaps for older people.
So with keratoconus, there's two things that I explain to my patients. One is the question of, look, are you progressing and do you need something to stop you progressing? And the second question is, what are we going to do for your vision? You know, what treatments do you need? You know, glasses or contact lenses, very rarely a transplant. So cross-linking for keratoconus is about stopping progression. So it's not a treatment for the vision. It's the evidence is that it's designed to stop progression. So to have the treatment, you have to be progressing. People with keratoconus progress generally do so before the age of 30. I have seen cases of progression in older people, but that's generally with eye rubbing, or they actually have a condition called pellucid marginal degeneration rather than keratoconus, and that's associated with sleep apnea and happens at an older age. So, you know, generally keratoconus begins in children, young adults, can get worse up until about 30 and then it's stable. Cross-linking involves UV light, and we always joke that we think maybe it's just by the time you're older you've had enough sun anyway and you sort of cross-link yourself. But so it's more, it's not so much that there's an age cut-off, it's more that, well, who's likely to progress? That's what, and so the treatment, you know, in doing the treatment, it's basically saying to someone, look, it looks like your eyes are getting worse, to stop them getting worse further. And there's been a large study done in, I think it was in the Netherlands, that showed that they actually had countrywide, they had less corneal grafts performed for keratoconus because they'd had the treatment. So, but once you've already progressed and stopped progressing, there's no sort of role for cross-linking.
Good evening. My name is Prakash. I just need a clarification on the keratoconus and PMD. So you say keratoconus and pellucid are brothers and sisters or sister brother or relatively close to each other?
Yes, they're both ectatic disorders of the cornea. So they've both got the sloppy sandwich. The difference is where the main point of thinning occurs. So the thinnest point in keratoconus is generally towards the centre. The thinnest point in pellucid is at the edge, and the cornea bulges up over that thin bit. Whereas in keratoconus, it's the thin bit that bulges. When you do topography, there's a classic appearance of pellucid marginal degeneration, and it's called a crab or claw hand. And so you see sort of like a crab, what we call a crab claw, which is the sort of thinning, the profile like this, whereas keratoconus is more sort of a circular profile. But it's basically diagnosed on where the thinning is and whether the bulging occurs with or above the thinning.
So the progression varies based on that you can diagnose it as keratoconus or pellucid, or the first itself you can diagnose it as a PMD or a keratoconus.
Sorry,
when you first examine the patient,
initial diagnosis,
initial diagnosis you can diagnose, or it takes a while for you to differentiate from keratoconus to pellucid.
Pretty much, well, usually initial. But I mean, having said that, in the clinics, you know, I'll see patients that have been told they've got keratoconus, and I'll have a look at if they've actually got pellucid. So whether they've had, you know, the topography done or whether the topography's been done, because you've got to not just get the contour, but you also got to get the thickness of the cornea, and some topographers will just do the contour as opposed to the thickness. And also you've got to do a detailed examination of the cornea.
The cross-linking will help for only keratoconus or as well as for pellucid.
The evidence around cross-linking for pellucid is, like, nobody's done any large clinical trials, and so we don't know for certain. It would have to be decentered, the cross-linking, because at the moment the cross-linking is focused on the centre of the cornea. Yeah.
Just, I was diagnosed at Kera University with topography saying as keratoconus. Then the cross-linking was done. After that it was known it was pellucid marginal degeneration. But a couple of months back, the Keratoconus Club asked for some research. The UNSW optometrist approached for the research data and everything. So when I went for the testing, from the first topography, so the students they diagnosed it as PMD, not keratoconus. And they said they have got the advanced topography machines in Sydney. They said. So if so, that's the based on the machine, it can be even the optometrist can diagnose very well the keratoconus or pellucid. Much the technology of the topography varies?
Look, it's not the machine, it's the clinician, so whether that's an ophthalmologist or optometrist. You know, the machines always give you the, you know, the backup to your clinical diagnosis. And so, you know, because the topography can also be inaccurate, like what I showed you with, oh, you weren't here, but before that, you know, once you've got advanced ectatic disease, you get errors in the topography. The topography, you know, the linear topography is less. And so you do have to have a clinical exam. You can't just do a test and spit out a diagnosis, or it's unlikely to be accurate.
And the last question, and you mentioned about the sleep apnea and people are aging for a PMD or something. So can you elaborate that one bit more?
Well, generally, there's an association between sleep apnea and pellucid marginal degeneration. Sleep apnea usually is a condition that occurs with greater age. And people wonder whether it's some form of collagen laxity, because, you know, the cornea is made mostly of collagen, and with sleep apnea there's laxity of tissue as well. Is this something we notice? Those patients also tend to get what we call floppy lid, where the lids can sort of avert easily when they're sleeping. So we think there may be some connection with lid laxity.
Hi, can I just ask you just just on the previous point just there, collagen. These are patients with
Yes, there are a bunch of syndromes that we have to compel to memory when we do our ophthalmology exams. We have to compel them during your studies as well, about these range of conditions that are associated with keratoconus, and some of them are things like Marfan syndrome, various sort of connective tissue diseases, and mitral valve prolapse, and so there are various other conditions associated with keratoconus. I think they're quite tall as well. People with keratoconus seem to be quite tall. That's just because I'm not tall.
You always have beautiful shoes.
Thanks. I guess just a couple of questions. Is keratoconus increasing around the world, or is it, where are the most prevalent hotspots for it?
Apparently there is a distribution that depends on UV exposure, but I don't know that we know whether it's increasing. I mean, with allergies might play a role.
I think that's nice. So I think there seems to be an increased rate of allergies. There are some reports that allergy rates are 3 times higher in the current generation amongst the children compared to the generation before. And I think if we've got that 70% to 80% association with allergies and keratoconus, one would think that perhaps keratoconus was on the rise. Now, the only other thing, though, that's a relevant factor this gentleman brought up is the fact that cross-linking often halts the disease progression in its tracks in lots and lots and lots of cases with a very high success rate. So, as a result, I think, you know, we may see more of it, but hopefully we see less of it progress to a state where more and more corneal transplantation is required. That's my theory anyway. I think the other thing...
I've got a theory too.
Yeah.
This is my personal theory. No, not peanut butter. I think a lot of it relates to allergens and pollutants in the air. Over 20 years of fitting contact lenses, I've noted a preponderance of people from Newcastle and Wollongong who've had keratoconus, and I think because there was steel industries in those towns, and I think there's more airborne pollution and people rubbing their eyes more vigorously. That's just my anecdotal experience. It's not a meta-analysis or anything like that. Maybe. But yeah, I've found over the years so many people from Newcastle and Wollongong have had keratoconus.
I've worked with some ophthalmologists across New Zealand and the UK and various other places, and some of those ophthalmologists have done a lot of corneal research as well across many different countries. And there's also lots of research that suggests that it's very demographic based too. So there's a strong link with genetics, and we know that with Pacific Islanders, it's a higher proportion of those have keratoconus. We also know also amongst the Arabic population, it's higher rates there as well. I've been looking after keratoconus for many years. I finally first saw my first Chinese person with keratoconus. And I said, "You are the first Chinese person with keratoconus." He says, "I look Chinese. I'm actually half Islander." I thought, "Oh, you're getting it well." So I don't know if you know Charles McGee. Charles was saying that because of the New Zealand Maori population, he's practiced in many different places in the world, and then New Zealanders, because of the Maori population, have the highest rates he's ever seen. So New Zealand has a very high rate of keratoconus too.
I mean, they think about 10% of cases that are possibly genetic, but that varies obviously with population.
Just going to finish up just a couple of questions that I had. My wife suffers from keratoconus for 48 years and uses the scleral lenses. And I was just wondering about the lack of oxygen to the eye. Is there any liquids or gels, oxygen-rich substances that you can use? Not San Pellegrino water or anything. That'll because she does wear them fairly throughout the day.
Not so much oxygen, but there are drops which have electrolytes in them, and electrolytes have been shown to be helpful for the goblet cells and the conjunctiva. So Biontears and Theratears drops are actually not available at the moment. But in terms of nutrition to the actual cells in the surface of the eye, that they definitely can help. But there's no drops that I know of which have high oxygen contents than others. That's not something which has been widely advertised or even studied, I don't think.
Yeah, just on that note, that's a very good question. The materials that we're using now and the way that we're fitting and prescribing contact lenses now, admittedly, Mark was right. Some of those case studies that I've used have probably been lenses that have been used for a very long time and a lot of neglect. But in the right circumstances, the lenses should allow almost 100% oxygen permeability now, unless you've got too much tears underneath the lens, which dilutes the oxygen getting through to the cornea. And then unless you've got a cornea which perhaps isn't the healthiest cornea or is an extremely old transplant with a really old corneal endothelium so that there's not enough oxygen being metabolically processed, I suppose, for what the eye needs, then most of the time, if that lens is using fairly good technology, you're getting it at very high rates of oxygen. The two things are oxygen deprivation and then also the biomechanical stress and then also metabolic byproducts. If they're using the right products underneath, if they're using products that might have high preservatives in them, like eye drops that are supposed to be reusable instead of preservative-free, then you're going to get metabolic byproducts build up, and then you're going to get neovascular growth and blood vessel growth because you're getting things that are pickling the eye that we don't want to come up at toxic levels.
Just finally, what age, Mark, do you have? What's your role as a patient wearing the sclerals? Is there a cutoff?
Not really. I think even patients in their 70s or 80s could definitely wear a miniscleral lens. We've got if she's not wearing a scleral, we've got a 94-year-old lady at the moment wearing a Bandage soft contact lens in her eye. So there's really no age limit in terms of who can wear them. In my time, I've only had one rejection case of a miniscleral, and this was a lady who's the worst keratoconus I've ever seen. She had a 77 diopter cone. We classified keratoconus, I think over 60 is pretty bad, and she was 77. She had extremely thin cornea. It was already scarred, so she'd had previous episodes, and I tried to fit it with a miniscleral and a cornea decompensated over it. She subsequently had a corneal graft. But I think in that situation, the miniscleral most really contributed to it. But I haven't had any other patients who've had that type of response wearing miniscleral. But the clearance of the limbal stem cells is absolutely critical. The old lenses I used to use, they would cause vascularization and things like that. The new ones are so much better.
I have a patient who actually Stephanie referred her to me. She's 85 years old. She came in to see me using her sister as a guide dog. She came in not being able to see the biggest letter on the letter chart. Like you had to come up to 50 centimeters away for her to be able to see anything. she was completely blind in one eye, and that was the vision that she had with the good eye. And I fitted her with a mini-scleral contact lens, and she had several corneal transplants in that eye, and she said, you know what, I haven't been able to see out of this eye for a very, very, very long time. And the moment that that scleral lens sat on her eye, she just sat back in the chair about 5 meters, and she just went, and she was just amazed. Like, she said, I can see you, like I can see for the first time in my life for as long back as I can remember. And she was just so happy to go, I want to go home, I want to see what my grandchildren look like. I've never seen them before. And I just thought, this poor woman, she's gone through most of her life not having seen. And that's the beauty of what contact lenses can do for you. She's still doing very well with the contact lens, but it's changed her life from not being able to see to doing what she needs to be able to see and going very well with them.
The real issue is insertion removal.
Yeah.
You know, if they get arthritis and they get very arthritic and they get Parkinson's or Alzheimer's, then it makes it very difficult to do insertion removal. If they've got a nice caring loved one who can do it for them, great. But that is really the limitation. And also the size, the aperture size of your eye. Some people have very small retracted eyes with very tight eyelids. They can be really hard to get a mini-scleral lens into. So that's most of the other biggest limiting factor.
Maybe we can just have one more question, is that okay?
Yeah, we can do more questions after.
Is that, if that's all right, yes, so we'll sort of try and close the formal session.
Probably don't need this. I've heard of some new potential technology called Keratoconus. I was just wondering how much you know of it and when we likely to see trials in Australia.
Are they like rings?
No, it's like microwave pulse in the eye, sort of heats up the cornea and then it's followed up with cross-linking.
Yeah, this is sort of part of what I was saying. There's lots of new sort of protocols that are coming on. I mean, it depends. If it's a device, the hurdles to get a device into the clinic are a lot less than to get a drug in. And so in the past, you've only had to show that it's safe. You haven't had to actually show that they work. Some of the regulatory approval is going to move towards more showing that they also work. So there's a lot of these sort of cross-linking associated technologies that are coming out, but there's no big trials or sort of registry data to show that they actually work. So with any treatment that comes out, I encourage you to check for the evidence behind it.
I'd like to say a huge thank you on behalf of everybody here for your wonderful talks tonight, again, for answering our questions and for giving up your time and your very busy schedules to answer all of these queries that we've had to. Thank you very much to all three of you.